All right, hopefully everybody is able to join fairly well. And can you tell me the number for the minty?
2490
2490
8220.
0. Okay. All right, if you haven't had a chance to join yet, the number's on the board up here. Okay, this, guys, I really wanted, like with everything that's going on with my mom, side note, I made a case study based on everything that's gone on with my mom. I really felt like everything that was happening to her was so applicable to what you guys are learning. So I turned in a little case study. So to update you later, you'll get to find out kind of what's been going on with her and hopefully learn a little bit. But while I was in Kansas the last few weeks, I was like, I've got to get back for diabetes. Like diabetes is just near and dear to my heart for many reasons, but specifically because of my son, Preston, who's been kind of our ongoing case study, right, with lots of things. But diabetes was kind of a big part of his life and his story. So this is Preston when he was 15. He's 18 now, just turned. And this was, you can see the Christmas tree. This was right before Christmas. He was playing basketball. And when I look at this picture now, I was thinking, gosh, he's kind of skinny. Preston went to a church camp that they go to. My kids go to this church camp every year, every winter, and he got sick, just like kids do in the winter. They all get together and they share germs. And I don't know if boys wash their hands ever if their moms don't tell them to, but all these kids came home kind of sick. Now I thought it was COVID, but he was testing negative, and kind of like since then, I kind of think it probably was COVID, and we'll talk more about that. Um, but that was the weekend. He was sick, had a sore throat. I noticed that he was drinking like a lot of juice. And I was like, oh, his throat's just really sore. That's probably it. And that was a crazy time for me because I was actually working, my full-time job was working like in surgery recovery area. And then I was adjunct here at the time. And I had like 3 call shifts in a row that week. And so I like was hardly home. And when I was, I think I was just sleeping most of the time. But I remember on Thursday of that week, right after the camp, he was still drinking so much. And I was like, gosh, he never drank. He even was drinking water. And I was like, he never drinks water. But he was drinking all this water. And then I remember he was going to the bathroom all the time. I'm like, man, that throat must be really sore. On Thursday night, and I think I was coming off another call shift, my husband got up with him because he woke up in the middle of the night and he was just like out of it. He wasn't making sense. My husband was like, something is wrong. He's back asleep now, and my son talks in his sleep and he's walked in his sleep before. So he's done weird sleep stuff. But my husband was like, something's wrong. So I had to go to work the next morning. I started at 5:30 in the morning. Got there. Several hours later, I think I'm on my breakfast break at like 8. And I'm sitting down, eating my little breakfast, and my son calls me. He goes, Mom, something's wrong. And he's a wrestler. So he was used to always weighing himself, right? If you have kids who wrestle, they're very they have to know what their weight is so they can wrestle in the right weight class. He goes, Mom, I've lost 10 pounds since last week. And you can see he's kind of a not skinny kid, but he's not a big kid. He didn't have 10 pounds to lose. As soon as he said that, it all clicked. Like, oh my gosh. He's been drinking so much. He's been peeing all the time. He always eats a lot. Not diabetes insipidus, diabetes mellitus. Yeah. Type 1. Yeah. So as soon as he said it, I knew. Because as a nurse, you're going to find there's things that you guys know. And when your family or friends are diagnosed with things, they don't understand it at first. My son didn't understand that this meant a lifelong disease, that he was always going to have to either poke his finger or check his blood sugars. I mean, they're so they don't understand the gravity, right? But we do. And I was just so sad. I went home and I kind of sat down with him and my husband and I kind of explained, hey guys, this is what I think is happening. And We called our doctor's office. They said, come in right now. I was surprised because they didn't check a blood sugar. They checked his urine. What do you think they found in his urine? They found a lot of glucose. At that time, there weren't I don't know if they even checked ketones then. They checked glucose. It was like in lab when we dipped the thing in juice and the thing is like glucose. That's what my son's urine was like. And so she said, my pediatrician, she goes, I'm gonna go home and pack a bag and you need to go to Mary Bridge. And so my son on the way home, he was like, so it's what you thought. And he just started to cry. And my son doesn't cry. He's like very like stern. And so on the way home, I said, buddy, in my head, I'm thinking, I know what the next several years, several months, several days look like. I go, if this wasn't an issue, if you had nothing else going on right now, what would you want to go do? Well, I want to go play video games with my friends and eat. Because he's hungry all the time and because he's diabetic. So I said, okay. So we stopped, went through a drive-through, got some food, and we went home and I said, 2 hours. Go play video games, get on, do what you need to do. Got him set up, and I went to my husband, I just cried. Because I knew what was happening. But I wanted to give him that little bit of time of just be normal. I'll go pack a rag, I'll go get this stuff ready, I'll make the calls we need to make, and you take that time. We went to the ER. Anybody want to guess what his blood sugar was?
624.
It was 643, I think. It was so high. I know, right? I was going, oh, and I remember feeling so bad because the ER at Mary Bridge was so full. And we walk in, I said, they said to come in, and he looked healthy, right? He looks pretty good. They check his blood sugar and we cut everybody in line. And they saw him, they did all the lab work. He was admitted to the ICU in Mary Bridge. We were there for 3 days. 3 days, and they sent us home. At first, I thought, oh, maybe because I'm a nurse, they trusted me more. They said that's our average stay. When somebody's diagnosed new onset type 1 diabetes, they send you home after 3 days, which I can't imagine learning how to do blood sugar checks, how to give insulin, how to do all those things in 3 days for a family to learn. That just seems wild to me. So while we were in the hospital, this is my husband. That's the first time that he ever gave an injection. I said, oh, I want to take a picture. He's like, no, like, this is a memory. Like, my husband is not medical at all. He's not interested. But for his son's sake, he said, no, I want to learn. I need to know. So this is where he had given. You can even see on my son, see the little drawing? That's from camp. I don't know why. Did Ashlyn come home with stuff? They had this thing of a theme. They just had this same camp this last weekend. This is my son's senior year now. And he came back with stuff, like they like tattoo each other with pen. So you can see he still has from the camp on there. Do I have one here? Oh no, I thought I had a picture. Amanda, her son Gabe was a year older than Preston. And they grew up together. They were good buddies. I think it was on the first day or something, but it was during COVID, like big, like not super lockdown, but everything was very strict. They couldn't have visitors. In fact, my daughter couldn't even go to see him in the ICU. But Gabe and Amanda brought Preston his Xbox so that he was able to hook it up. And while he was there, he was able to still play video games with his friends, which I think was so loving of just like, hey, this horrible thing is happening to you, but let's figure out how to still do normal things and still live life. We did have to do insulin injections and finger sticks for several months. I was like, I'd rather have a CGM where they can wear it, and I'd rather him have a pump. You know what they told me? This is so smart. You have to know how to do it a low-tech way because that technology might fail. And if your technology fails, we need to make sure that you know how to check your blood sugar with the finger and how to draw up insulin. Okay, that's smart. I know how, but he might not. So he knows now. And that was really hard. We did though, after a few months, we got his first insulin pump. We'll go over the pumps probably more next week. We'll talk about them, but this is the type of pump that holds insulin inside of it. It's good for 3 days. Every 3 days, you have to change it. And he was really happy to have his insulin pump. And now, is this now? Yes, these are some of his senior pictures. I asked him, I was like, last night, I was like, oh, this is it was an old picture. So what picture do you want? So he wanted this picture. This is him and his sister and my husband, when he had his senior pictures. And he's doing so well. Like he went away to a winter camp and I wasn't there. And they go to this winter camp that has no cell service, no internet. And so I was in the dark for 3 days of not knowing where his blood sugars were or like how anything was doing. And he couldn't call me if he needed me. It was terrifying. I don't know how people like, how did parents do this 20 years ago when they couldn't like see their kids? It's wild. But I'm so thankful. And there's a lot of technology that kind of helps us. That's one of my friends who was a diabetic educator. As soon as I found out he was diagnosed, I kind of said things in our head, like as nurses, sometimes we know and we can kind of see people's futures, right? Doesn't mean it's going to always be a certain way. But when somebody's diagnosed with hypertension, we kind of know, hey, if you want to live a healthy life, there's some things you probably need to do. All those diseases, we kind of see it. With diabetes, when I was a younger nurse, we didn't have a lot of the types of insulins, types of medications, the technology that really helps them now. And so the type 1 diabetics really didn't fare very well. They had shorter lifespans. A lot of them lost a lot of feet, limbs because of uncontrolled diabetes. It's so much easier to control it now what my friend told me, because I was like kind of freaked out, like, oh Lord, he's gonna lose a leg by 30 and be dead by 50. Like which I mean sounds so awful, but I'm like, it might be. She goes, you know what? She goes, with all the technology advances, the new things that we have with insulin pumps, with continuous glucose monitoring, she goes, we haven't seen a generation of kids grow up with this. We don't know what life's going to be like for them, and it's probably going to be a lot. And that really spoke to me. I was like, oh, that's true. Like I have an app on my phone where right now I can see his blood sugar is 176 and the little arrow says it's kind of stable. I'm fairly happy with that. I wish it was maybe a little bit better, but honestly, it's below 200. His A1C right now is below 8, which is okay. We'll get more into this, but one of the big things with this too is that we've always told Preston, this is your disease. We're here to support you. We want to help you, but it's up to you to manage it. And but eventually it's going to be you to do this on your own, because he was diagnosed so much older at 15. And that can be very common. Kids up to, I think the youngest is usually about 2 years old. And then you could even, with type 1 diabetic, you could even be diagnosed in adulthood. We'll talk a little bit more about that. I think I want to talk a little bit about the pathophysiology of it, but before I go into this, I want to show you guys a fairly short video because I think it's really helpful of talking about the different types of diabetes. So just so you know, Preston is a type 1 diabetic, okay? We generally classify type 1 diabetic, type 2 diabetic, and then there's kind of like other types, which this video does a great job of showing it. So let me pull this up and play.
Is a group of disorders that's caused by improper function of insulin, which is a hormone responsible for regulating blood sugar or blood glucose. And this results in hyperglycemia. But since diabetes is a group of disorders, there's many different underlying pathophysiological mechanisms that can cause the disease. And depending on which mechanism is occurring in someone, the presentation of the disease can actually be very different. So before we get started, I want to briefly talk about the pancreas. Now you can see here we have the esophagus coming down and it dives behind the liver here. And then it goes into the stomach. And then the stomach goes back behind the liver and comes out as the small intestine.
This is not the video I wanted. Hold on.
Next to the small intestine and behind the stomach.
Okay, well, now you know where the pancreas is at. This is not a bad video. I watched this one too, but there's one I like better. Hold on.
There we go. All right, sorry guys. These Khan Academy videos are really good.
It's caused by improper function of the hormone insulin, which is secreted by the pancreas. Now, this results in dysregulation of blood glucose levels in the body, specifically resulting in hyperglycemia, or high blood sugar, which is the element of diabetes. Now, since diabetes is a group of disorders, this implies that there are multiple different conditions that can lead to diabetes mellitus, which is true. So let's break down diabetes into three major types. Type 1, Type 2, and a third category which we'll just label as miscellaneous. Now, before we dive into these three types of diabetes, let's briefly review how the hormone insulin works. In response to increasing blood glucose levels, the pancreas produces and secretes a hormone known as insulin into the bloodstream. And this insulin acts on cells throughout the body to remove the glucose from the bloodstream by either taking it up to use it for energy or to store it in the form of glycogen. And as a result, the blood glucose levels decrease. And these decreased blood glucose levels then serve as a feedback mechanism to inhibit the pancreas from secreting more insulin. So you can see that there are two major steps in this insulin pathway. First, insulin must be secreted by the pancreas in response to this increasing blood glucose level. And second, the cells throughout the body must respond to insulin in order to carry out its metabolic functions in order to lower the glucose levels. Now, this mechanism can be thought of as similar to that of a thermostat in an air conditioning within a home. When the temperature goes up, this is sensed by the thermostat, which then sends an electrical signal to turn on the air conditioner, which will then decrease the temperature. And as the temperature goes down, this will inhibit the thermostat from continuously keeping the air conditioner on. And this mechanism here is going to become very important in just a minute as we differentiate the different types of diabetes mellitus. So let's go through each of these types individually. Type 1 diabetes presents mostly during childhood, and it's caused by a genetic predisposition, plus some sort of environmental trigger. Exactly what this is isn't quite known, but the combination of these two results in an autoimmune disorder, in which the immune system attacks the beta cells of the pancreas to prevent them from producing insulin. On the other hand, type 2 diabetes typically, although not always, presents during adulthood, and it's even more strongly associated with a genetic predisposition. But in type 2 diabetes, instead of this unknown trigger, the genetic predisposition is accompanied with other predisposing conditions, such as obesity or hypertension. And this combination of factors results in an inability of these cells throughout the body to respond to insulin. Then, although type 1 and type 2 diabetes are the most common causes of diabetes mellitus, there are a couple other important causes of the disease, and these include diabetes caused by medications, known as drug-induced diabetes. And drug-induced diabetes most commonly occurs with a group of medications that are known as glucocorticoids, which are steroid medications most frequently prescribed to decrease inflammation throughout the body, such as with conditions like chronic asthma or Crohn's disease. And the other miscellaneous cause of diabetes mellitus that's really important to mention is the diabetes that's associated with pregnancy, known as gestational diabetes. Now, let's tie this all together to receive a better understanding of how these different types of diabetes affect this underlying insulin pathway and result in diabetes mellitus. In type 1 diabetes, this autoimmune attack on the beta cells of the pancreas prevent the production and secretion of insulin into the blood. Thus, type 1 diabetes inhibits this first step in the insulin pathway. And since it decreases the production of insulin, it's referred to as an insulin deficiency. However, in type 2 diabetes, as well as drug-induced and gestational diabetes, the pancreas continues to secrete insulin. However, it's the cells throughout the body that are unable to adequately respond to it. So in a sense, these mechanisms inhibit the second step in the insulin pathway, and this is known as insulin resistance, which can be thought of as a relative insulin deficiency. So going back to this thermostat analogy, if either the thermostat or the air conditioner is broken, the system as a whole doesn't work. The temperature inside the house is going to continue to rise. Similarly, in diabetes mellitus, it doesn't matter whether the underlying mechanism affects this first step, such as with type 1 diabetes, or the second step, as with type 2 diabetes, drug-induced diabetes, and gestational diabetes. Regardless, there's going to be either an insulin deficiency or a relative insulin deficiency, so this pathway will not work, and the body won't be able to decrease glucose levels. This results in an increased level of glucose, which is known as hyperglycemia, which, as I mentioned at the beginning, is the hallmark finding in diabetes mellitus.
Sometimes if you have trouble.
Now, diabetes mellitus is a group of disorders that's caused by improper function.
If you have trouble understanding some of these concepts, the Khan Academy is one that I like to use, as well as osmosis that I've shown you guys. I really encourage you to look those up, like watch them. Sometimes even like watching one video, then another one, something will click sometimes. So if you're having trouble with concepts, you know, look at other things too. Let me get back to the Menti. Here. The owl isn't working. Okay. All right, let's go back to this Menti and let's talk more about diabetes. So, okay. So like the video is saying, when we're talking about diabetes as a whole, there's issue with the insulin, either the production or even like the metabolism of how the body's receiving the insulin. You can also have some altered carbohydrate, fat, and protein metabolism, meaning how you metabolize those can be a little bit different because of the insulin's malfunction. And we're going to have long-term complications. We're going to talk about long-term complications next week. Preston was diagnosed with insulin-dependent diabetes. So thinking back to what I talked about and what the video kind of said, what changed inside of his body? Kind of. Yeah, so you guys are on the right track here, right? His ability to produce insulin, his body no longer produces insulin. Yeah, so that's the main thing. And so do you guys remember from the video where in the pancreas the insulin's produced from? Yeah, the beta cells. There's these cells on the outside of the pancreas that produce insulin. Now, our pancreas does so much. Like we were just talking about with our kids with cystic fibrosis, right? They have some issues with not this side of the pancreas, but some of the digestive stuff that the pancreas produces. It's just this one specific part of the pancreas. And it's not that they are dead, it's some genetic piece that just kind of switches them off. Like they're these little tiny factories on the outside of the pancreas, and those beta cells are, and those factories produce insulin. For some reason, with type 1 diabetes, there's somebody comes through each one of those little the factories, and just shuts them down. Now, if we could figure out how to turn them back on, they could still work. So there's a lot of innovation, a lot of things put into trying to figure out how do we go back and get those beta cells to start working again? I mean, wouldn't that be amazing? And yes, it is autoimmune, right? Specific
specifically with type 1 diabetes, it's an autoimmune issue, where type 2 diabetes and gestational diabetes aren't autoimmune. There's always, so both type 2 diabetes and type 1 diabetes have a genetic component, even stronger in type 2 diabetes. In type 1 diabetes, it's very interesting because you have to have some genetic component in you, and it might not ever manifest, but it might. With that genetic component, there also has to be a trigger of some sort. Usually gradual. It's not gradual because it's just sitting dormant inside of you. The genetic component for type 1, I'll talk about type 2 in just a minute. Type 1, it's just sitting inside you dormant. And there's something that will trigger it. It'll trigger that autoimmune reaction. It's usually a virus of some sort. Like my son had a cold, some sort of viral issue, and all of a sudden that triggered this genetic component to now be active. And they started attacking the beta cells of the pancreas. You'll see that quite often. And in fact, the reason why I say I thought he probably had COVID is because the CDC is doing a lot of research and looking, because during the several years after COVID, they noticed there is a huge uptick in kids having type 1 diabetes, specifically after having COVID. And so they don't know what the correlation is, or they don't know if it's causation. They said there's a big correlation. We can't prove that COVID caused type 1 diabetes, but we can say in our nation, these kids got COVID and a whole lot of them got diabetes, way more than what was usual. So it's something very interesting. Just to look at. You talked about different diseases and things and how they come about. There's a lot of kids out there with type 1 diabetes. I don't know percentages right now. I know it used to be low percentage for type 1 diabetes. My guess is in your practice as nurses, you're going to see a lot more type 1 diabetics because of the pandemic. So we'll see. With type 2 diabetes, you have a genetic component, but it's not autoimmune. It's a genetic component where your pancreas, oftentimes it's still producing insulin, but what happens is you're producing insulin, but oftentimes if you're overweight, you're more sedentary, your cells don't want to accept the insulin. I always think about insulin, it's produced by the pancreas. So if I'm the pancreas, I'm throwing out insulin all through the bloodstream. It's going to all of you guys. Let's say you guys are the cells. Like these are our blood vessels that are going through. So I'm sending out insulin to you. Oh no. I'm sorry. I'm gonna go back. Anyway, I said that differently. Let's say I'm the stomach first. Okay. I'm eating. I've got all this, I ate all this candy. I've got all the glucose. And I'm sending glucose through the blood system, right? All of you guys, you're all these cells that want the glucose. But if you don't have insulin, the pancreas, once you start eating, it starts producing insulin. And that insulin is like a key. So it says, oh, here you go. I'm going to open up the door so you can have the glucose. And you have, so that's how, that makes more sense to me. Because what we see, like with Preston, he had tons of glucose in his system, right? But he was starving, right? He had lost 10 pounds and he was eating and drinking all the time because his stomach was providing all of the glucose. We're starving. They couldn't get any of that because he wasn't making insulin to let it into the cells. Does that make sense? With type 2 diabetes, oftentimes we're eating a lot of sugar. We're getting lots and lots of sugar everywhere. And our pancreas is doing a pretty good job at sending, okay, more insulin. We kind of get a little bit lazy as these cells. We're like, oh, another glucose. And then maybe instead of, I'm just going to say 1 key of insulin, it might start taking 2 keys to open the door so I can get the glucose. It's called insulin resistance, where normally with only this much insulin is how much it would take to get the glucose into the cells, it starts taking more and more insulin to get into the cells. You guys are going to see some patients. I look, when you're out in clinicals, diabetics, there's some people who take crazy amounts of insulin. Like, maybe somebody who takes, normally, I don't know, 15 units of like a long acting insulin, Lavemir, right? And then a little bit of short acting. And then you have some people who have a lot of insulin resistance and they're taking like 100 units of the long acting and 30 units of short acting with their meals. I mean, it's crazy. You could have a lot of insulin resistance. We'll talk more about it. I think next week we're going to talk more about insulins, but it's just really interesting. Okay, I got sidetracked. Let's see, what are we talking about again? Okay, so they used to call type 1 diabetes juvenile diabetes. That's because it usually happens with kids. That's usually where we see it. But you can have adults. I have a good friend who's a type 1 diabetic, and she was diagnosed in her 30s. She had that genetic component, and it was dormant in her until something triggered it, and an autoimmune attacked her pancreas. Like I said, only 5% of diabetic cases, it's pretty low. I'm guessing that number is going to be going up a little bit just after COVID, or I don't know. Our nation's really overweight and unhealthy, so we might have a lot of type 2 diabetes too. Type 1 diabetes is an autoimmune response. They destroy the beta cells, and the pancreas will not produce insulin. So these guys are going to need insulin for the rest of their life, right? Because we can't, right? If the stomach's out here feeding all the blood vessels, we have to have insulin. It was really hard for my son when he was diagnosed. A lot of people were like, "Oh, I have the best diabetic books and cookbooks for you," and but they were like thinking type 2 diabetes with like low carb, low sugar. My son's doctor said, "No, he can have carbs, he can have sugar, he needs it. He just needs insulin." So my son eats, well, probably too much sugar and sweet, but he eats like a normal kid. He just has to take insulin with it because otherwise he can't metabolize it. Usually you're going to see younger patients and they're usually pretty thin when they're diagnosed. The onset can be sudden or it can be maybe over a couple months. It just kind of depends. Each person is different. But usually they're pretty thin when they're diagnosed because they're just losing weight because their body has all this sugar, but they can't access it. So if they can't access it, what are they burning for energy?
They're burning proteins and fats.
Yeah, they're burning fat, they're burning their muscles, they're kind of losing their good weight, a lot of them. They're more prone to ketosis. And we'll talk about that more next week when we talk about the complications. Yeah.
There was something I remember that we read about like an eating disorder with type 1 diabetics, is that like when they don't take insulin, they can lose a lot of weight, or like there's
Trying to get ready
yeah, like
for a wedding.
that what?
They're trying to get ready for a wedding.
Yeah. With like in teenagers, like it was something, there was an ADI
There's-
question about it too. of,
There's a
like,
lot of eating disorders associated with type 1 diabetics. And a lot of, when you think about it, you tell kids, hey, you need to count every carb that you eat so you can give all the insulin. You're so focused on food. There's a lot of eating disorders with it. If you find the question, bring it up. I'd love to look at it. All right. Type 1 diabetics, they're going to need insulin for life. And let me tell you, insulin is getting a little bit less expensive. It's still expensive. I have really good insurance. I pay so much to have really good insurance. The insulin's okay, but to get them to pump and the other things to make it more convenient, it's so expensive. It's crazy. Which, I get it. Like, you don't have to have it, but for compliance, for the quality of life, for longevity of controlling the disease, man, I wish I could go talk to our legislators and be like, listen, if you're going to lower insulin costs, lower the cost of how we get it too. All right. Oh, yes, of course.
Insulin pump. So when you change everything, now it's
Different side, yeah. Yeah, because it has a little auto injector thing that he does it all on his own for a couple years now. He fills it up with insulin and then he puts it on his skin and it has like a tegaderm type thing. It like seals on there. And then it has a little auto injector that it has a needle that it hooks a little tiny catheter into his skin. Because remember, if you're giving insulin, what type of injection is that? Subcutaneous, right? We want it to be kind of a slow release. So it goes into a subcutaneous skin. Goes here, he often does it on his belly or his legs too. Those are his favorite spots. But you can do it anywhere you have. I know some people who do like at the bottom or like wherever. I saw some marathon runner, or no, who's triathlete, who had it like on his back up here. What was that? But yeah, and then you want to make sure they change the sites, just like an insulin. You want to rotate your sites around. So for that, you want to make sure you rotate your sites around, but also with the pump or with the continuous glucose monitor, you're ripping off a layer of skin. And if you keep ripping off layers of skin, you're going to be more prone to having infection or skin irritation. So they also, not only because you don't want to build up scar tissue there from the injection, you want to rotate because you want to look at the skin. Okay, now we can talk about Richard. Richard's my dad. Richard does not have an autoimmune component, but he did have a genetic disorder for having type 2 diabetes. As he got older, he got a little more sedentary, a little more overweight. Blood pressure was high, cholesterol was high. What did he get diagnosed with? Type 2 diabetes, right? Because his body, for the most part with him, it was that insulin resistance. His cells were saying, I need more insulin than that, and more and more. And so now he is on some medication to start helping to keep his blood sugars low. And if you look at both my dad and my son, both of them have high blood sugars at times. Both of them have signs and symptoms that are similar, right? What are the symptoms of high blood sugar? Thirsty, hungry,
Frequency.
and peeing a lot, right? You're peeing a lot. They both have those symptoms sometimes. So either way, regardless of what's causing the issue, a lot of times the symptoms are the same. Management might be a little bit different though, right? With Preston, his body doesn't produce insulin, so we have to give him insulin. With my dad, you know, sometimes, well, am I getting ahead of myself? You guys don't have to type it in. We'll talk about it. A lot of times, lifestyle modification can manage your diabetes. Just like high blood pressure. We talked about, hey, what's our first step for high blood pressure? Lifestyle changes, right? What are we going to encourage our patients to do?
Exercise.
Yes.
Be healthy.
Right? Yeah, all these things. It's kind of the same for diabetes. We're going to talk a little bit about pre-diabetes in a little bit. So once we see patients that maybe are becoming pre-diabetic, we encourage them, hey, look at your lifestyle. Let's start getting some more activity. Let's exercise. Let's look at the foods we're eating. There's a lot of people who were diagnosed with diabetes, type 2, but they don't take any medication. Look for those patients when you're out in clinical. A lot of times they'll say, what happened? They go, oh, I lost 30 pounds. Didn't need my medicine anymore. I'm like, that's amazing. If my dad would lose some weight, he probably wouldn't need his medicine for his blood sugar. He probably wouldn't need his medicine for high blood pressure. You know, there's a lot of things that kind of go into that. There's a large genetic component. Sometimes you can have a reduced number of beta cells. Sometimes they've seen, especially if there's insulin resistance, the cells are needing more and more insulin to let the glucose in. Those beta cells are like those little factories are like working their hearts out. They're just trying to get all the insulin. Sometimes you can have damage to those beta cells from just overproducing so much insulin, and they can stop producing as much, or some of the cells will not work as well. The biggest risk factor is obesity. And they're not usually ketosis prone because they're still, actually, you guys tell me, why aren't they ketosis prone?
The pancreas still secretes insulin.
Yes.
Rather than the alpha cells secreting the glucagon.
Yeah, both of them with the alpha cells, they still work the same.
Okay.
But my dad still produces insulin. So he's still getting some glucose into the cells. Enough to be okay, usually. With my son Preston, he's not getting anything if we're not giving him insulin. And that's when the body starts breaking down the fat, breaking down the protein, the muscles. Okay, with type 2,
bigger emphasis on lifestyle modification. Usually they start with oral medication. With type 2 diabetics, you don't want to start them on insulin right away. Occasionally, in acute care in a hospital, they might give them a little bit of insulin to lower the blood sugar. But when you're treating them, just like, we might start with lifestyle choices. If those aren't effective, they're going to start with oral medications first. We're going to go over oral medications in a little bit. They work in different ways. It usually progresses, you can progress to needing insulin eventually, because of that insulin resistance. Sometimes even if all the medications we give them are pills, because of the resistance that builds, you end up needing some insulin as well. It is chronic, there is no cure. Just like people who say, hey, I exercise, I eat healthy, I do good, I don't have to take my high blood pressure medicine anymore. Do they still have hypertension? Yeah, it's just controlled with their lifestyle. People who are diagnosed with type 2 diabetes, if they exercise, they eat well, they might not need their medication anymore. But do they still have type 2 diabetes? Yeah. Yes, it's just controlled with their lifestyle. If either one, hypertension or diabetes, if they start being sedentary, eating all the things that are so delicious, they're probably gonna need to start taking medicine if they don't do changes. The CDC said that more than 34 million people in the US have diabetes. This is crazy. 34% of people in the US have pre-diabetes. Over a third of people in the US have pre-diabetes. That means that their body is primed and ready to go into diabetes. We'll talk a little bit about it. Third, you said 2 out of 3? Okay, we'll talk dosage later. One thing to look at is, anybody heard of apple shape versus a pear shape? Yeah, so if you are, and this is what they say, apple shape is more like above the waist, you're more round here. That's actually fat and weight that's harder on your heart, makes you more at risk for high blood pressure, high cholesterol, diabetes, those types of things. If you are overweight and your weight is more in your hips than your bottom, good on you, and you're less likely to have some of those issues. Now, if you're overweight and most of your weight is below, yeah, you're still gonna have, you're still potential for having hypertension, diabetes, and all those things. But it's kind of helpful to look at patients. If you have a patient that walks in and they start telling you about different symptoms, and you're thinking, oh, there might be some high blood sugar, some other issues. If they're apple shaped, that's going to even concern us a little bit more, right? It's a diagnostic observation. It's not a pear shape, though. Well, it's just what they call it. It's just made up of 24. Oh, this was, sorry. There is diabetic type 2 diabetes in children that we're seeing now. As a nation, as we see more kids that are overweight and not active, we're starting to see kids with type 2 diabetes. It's pretty wild. Okay, here's a question for you. If a controlled type 2 diabetic states, the doctor said if my blood sugars remain stable, I might not need to take any more medicine. Which response is the most appropriate? 1, you'll be placed on strict low sugar diet for better control. 2, some doctors do not treat blood sugar elevation until symptoms appear. 3, diet, exercise, and weight loss can eliminate the need for medication. Or 4, you misunderstood the doctor. Let's ask. All right, well, most of you are correct, and it is diet, exercise, and weight loss can eliminate the need for medicine. It is true. Would we still want to ask if they need it? Yeah, we probably would want clarification, but F.A. Davis says that diet and exercise and weight loss is the correct answer. Other types of pregnancy. If anybody was diabetic during pregnancy, do you want to share? Yes? Yeah.
Both of my pregnancy.
Really? And then did it resolve after you were gave birth?
No,
Oh,
I am trying to
Oh, stink. Yeah, which,
But also my family background, also have.
long history.
Yeah.
Yeah. Yeah, because what we found is that with all of the hormonal changes, everything that happens with pregnancy, you're more likely to develop a pregnancy-induced diabetes. Now, oftentimes it will resolve once the mother gives birth. Blood sugars normalize. Unfortunately, if you're predisposed to having diabetes already, it might stay. My sister just had her 5th baby, and she had gestational diabetes. And I'm like, girl, you better be careful, like exercise and eat good, because she's with my dad's history, we know that she's really high risk. Pre-diabetes, we're going to talk about that more in a minute. And then there's secondary diabetes, meaning you can have drugs, medications, right, that can damage the pancreas. You might have some diabetic type states from a damage to the pancreas. Sometimes it can resolve. Or if you have pancreatic trauma, right? Somebody has a car crash and massive abdominal wounds, they might become diabetic just from the actual damage to the pancreas itself, not necessarily like a genetic type condition. Does that make sense? Yeah, we're not going to talk too much about that. You won't see that very much. I won't test you on it. Okay, so I want you guys to tell me true or false. Type 2 diabetes occurs as a lack of insulin production. Is that true or is it false? All right, well, nobody's going to vote against the crowd yet. Oh, they did. It is false. Okay, sorry, I was like, am I reading that wrong? False, right? Because which type of insulin is from a lack of insulin production? It's type 1. Yeah. All right, pre-diabetes. These little arrows here talk about 3 different lab values. So if we're looking at fasting blood glucose, what is fasting blood? What does that mean?
Your glucose when you're fasting.
Yeah, right. So first thing in the morning, or it's been 8 hours since you had anything to eat or drink. Your glucose tolerance test, what does that mean?
Oral solution of glucose.
Yeah,
Checking.
a lot of, if you've been pregnant, you probably had to take it, right? Like we all did. And that's just to see, how does your body tolerate glucose? We do this test in pregnant ladies because we're screening for gestational diabetes. You tell them, don't eat anything, and now drink this syrupy, gross thing.
Yeah.
It's a bunch of sugar. And then you check to see how the blood sugar is about 2 hours after. Your blood sugar should go in like waves, right? You eat, your blood sugar should elevate as all that glucose goes into the cells, right? But then as our pancreas is producing insulin, it should gradually go back down, right? And then hemoglobin A1C. Anybody want to take a stab at describing that?
Your glucose levels over 3 months.
Yeah, yeah. So it's just such a nerdy fun fact, you guys. Sometimes they call it's HbA1c, hemoglobin A1c. Hemoglobin, where does it live? In your red blood cells. How long do your red blood cells live? 120 days. Over time, if your blood sugars are too high, that glucose attaches onto the hemoglobin, into those red blood cells. So what you can do is you can test the hemoglobin in the red blood cells and see how much glucose is attached. Because if you have too much glucose in your system, it sticks to those hemoglobin particles. So that's why it's over a range of 3 months to say, let's get an average of how much glucose you have that's stuck to your hemoglobin. Isn't that interesting? So it's not just a random number. It's like, oh, that makes sense. So A1C is really helpful to say, what's the average then? Okay, just like we know with our tests today, if the average is 84, I don't know what the average is. Does that mean that everybody got an 84 on this test? No. No, right? Some days people's blood sugars might be higher, some days it might be lower. It's an average. So it can be helpful, but it doesn't mean that somebody's taking really good care of their blood sugars. This is very helpful though, because a lot of patients they would just be like living wild. And then if they knew they were coming into their doctor's office, they would eat real good. And they say, look, my blood sugar's so good, it's 101. And they're like, survey shows that you lie. Like, you're not gonna look that up with somebody, so they couldn't just cheat around it. Okay, so let's look, because these are normals, okay? So our fasting blood sugar, without eating or drinking, you should be less than 100. Your glucose tolerance test, if your normal function, you drink a soda right now, in a couple hours, you should be less than 140. Right, we expect the blood sugar to go up a bit if you eat sugar, but it shouldn't go crazy high. A1C should be less than 5.7. I know. Mine's 5.7. My doctor keeps doing this to me. It's really stressful. Okay, then we have, I'm gonna go up to diabetes first, then we're gonna go to pre-diabetes. Okay, so if you have diabetes, your blood sugar, when you're fasting, is often 126 or higher. That's just your baseline. Doesn't mean you have to be that. If you take medications, it might be lower, back down. If you do a glucose tolerance test and you're not taking insulin or medication, that sugar is going to spike up your blood sugar to over 200. Was yours over 200 when you did yours?
Yes, I was telling them fasting blood glucose.
Uh-huh.
Mean that you give anything, it goes to 140,
Really? And then what was yours when you did your glucose tolerance test?
300.
Ooh, you're so sweet. Oh, and then your A1C, if it's 6.5 or higher. Diabetic. Fun fact, you guys know, remember I showed you the picture of my son, he has this deviated septum, we have surgery next month. Did I tell you his A1C, they took it and it was 8.3, I think, not very good news, but it's his disease, we're helping you gotta manage it. And the doctor said, you can't have surgery with A1C above 8. The anesthesiologist won't do it. Because it means you're not controlled well. And to be optimized for surgery, to be healthy for surgery, you have to show you can control your diabetes. Guess what his A1C is now? Below 8. I think it's like 7.8 or something. It's much better. But, you know, he can't define his motivation, right? Okay, so that's diabetes. Now we have pre-diabetes, right? 1 in 3 people in the US have pre-diabetes, which means their fasting blood sugar probably between 121 and 125. I'm not going to test you on these numbers. I do want you guys to know, like the 6.5, like that's, or less than 5.7, like those are good things to know. I don't care if you know the specific glucose numbers, okay? Pre-diabetes, if you do that glucose tolerance test, 140 to 200. Pre-diabetes, 5.7 to 6.4. Since mine is 5.7, that's why my doctor is like, okay, don't eat as much chocolate. And I'm like, it's tough. So good. Part of pre-diabetes, we look at something called metabolic syndrome. This is something that kind of all comes together that shows us that patients are having some issues that all kind of combine together. Syndrome meaning there's a bunch of different signs and symptoms, that it's not just like a disease process, but just kind of a variety of symptoms that come together that are common. So metabolic syndrome, you'll see with patients who have an elevated waist circumference. So sometimes you'll see this when we're screening patients to come into a doctor's office, they might ask for what their waist circumference is. And it's not that they're trying to like buy a belt, it's that we know that averages, if, oh, I can't remember, if it's 32 inches, men and women are a little bit different, but there's a certain number that if your waist circumference is larger than a certain amount of inches, you are more likely to have that abdominal fat that's harder on your heart, harder on your metabolism and your blood sugars. We're also going to look at your triglycerides. Like we talked cardiac earlier this term, right? Elevated triglycerides, as well as low high density lipoprotein, the HDL. Because remember, the HDL is good. It's cardioprotective. We want that. And if that's low, if you have elevated blood pressure, HDL cholesterol, oh, that's just connected there. Elevated fasting plasma glucose, we check it, fasting glucose, if it's elevated, they are at risk for type 2 diabetes. They're also at risk for high cholesterol, hypertension, but metabolic syndrome is these kind of this group of symptoms or lab values that when we look at people, you might see metabolic syndrome listed as a diagnosis for people. And it's not that we want to start them on medicine to treat metabolic syndrome. It's saying, no, that they've got these things going on, but we really need to make sure we're screening them for certain disease processes. Kind of make sense? Okay, I think we're almost done and we're gonna have a break. Okay. Just tell me, nurses providing education for a client who's newly diagnosed with diabetes mellitus. What are the classic symptoms with diabetes?
Aphasia.
Mhm. The three polys, right? What's,
Urinary.
yeah, polydyspnea or dyspsia is thirst. Aphasia is eat. Urea is pee. Think of my son drinking all that water and juice. Like I could not believe it. It was bizarre. Okay, it's polydyspnea, dyspsia, polyuria, polyphagia. Because first of all, especially in type 1 diabetics, their cells are starving, right? That's partially why they're so hungry. In type 2 diabetics, they can have a little bit of lack of that. They usually don't break down so many proteins and fats because they're still producing some insulin. But you get all this glucose in your cells, or in your, pardon me, in your bloodstream, and you actually get a little bit hypertonic. So that's part of it, is they're trying to drink a lot of water to flush out that glucose because they're hypertonic. And their body is trying to excrete the extra glucose and excrete the extra fluid. So that's why they pee a lot. They're also usually dehydrated because of that. They're tired because their body isn't getting insulin or getting sugar, glucose into the cells to work effectively. So they're tired because they're not working like they should. They can have blurred vision with high blood sugar. You can get blurred vision. They can get more prone to infection. Sometimes you can have abdominal pain, kind of cramping when your blood sugar gets high, headache, and then we'll talk more about ketosis next week. We talked about the diagnostic testing. Okay, a client's evaluated for type 1 diabetes. Which client comment best relates or correlates with this disorder? I'm thirsty all the time. I can't get enough to drink. It seems like I have no appetite. I have to make myself eat. I have a cough and cold that just won't go away. And I notice pain when I urinate. Good job, you guys. I'm thirsty all the time. I can't get enough to drink. A nurse reviews a client's hemoglobin A1C. Which test result indicates a client's blood glucose level has been well controlled? Yeah, nice job. 6.5. Usually less than 7%. Did I put that on here? Yeah. Less than 7 is usually 7 or less is what we aim for our diabetic patients, which I can see where some people would say like, but wait, on the arrows, if it was 5.7, you were pre-diabetic. That's just looking at your risk of getting diabetes. Once you have diabetes, we know that your blood sugar levels are not going to be normal. They're just going to be elevated by nature of the disease. So if we can keep the average blood sugar, I don't remember what is 7. There's like a chart where you can say a blood sugar of 130 equates to a hemoglobin A1C of 6.5. I'm making that up, but there's some sort of chart where it kind of gives you, you're probably an average of this number. So we know that patients with diabetes are going to have high blood sugars, higher than normal. So if we can keep their A1C below 7, we're usually saying good job, right? With my son, it was below 8 to do surgery. We encourage them to do some activity. And in type 2 diabetics, oh, this is prevention. Sorry, in prevention, if you can lose 7% of your body weight, you're overweight and you have prediabetes, a lot of times you can get rid of those symptoms and you're controlled with your lifestyle. Activity can help. And then some patients who are pre-diabetic, they might give them metformin just to help prevent them from going into full like diabetes. We talked about this, therapeutic interventions, right? We're gonna teach them how to eat, what to eat, exercise, monitor. Some of our pre-diabetic patients, we might have them checking their blood sugars just so we can see what are you trending, what's happening with your blood sugars. What are risk factors for type 2 diabetes? Select all that apply. Risk factors for type 2 diabetes. Okay, got varied responses. I like this. For the most part, we're good. So obesity, absolutely. Hereditary, yeah. With type 2 diabetes, there's a big hereditary component. Everybody say bye to Amanda. Bye, Amanda. Have a, I know, I was gonna have a good dentist appointment. Islet cell antibodies, right? No, when we're talking about antibodies, we're talking about type 1 diabetes, right? Metabolic syndrome. Yeah, that makes, if you have metabolic syndrome, you're at more risk of having diabetes. And insulin resistance. If you have that, you are more risk of developing diabetes, type 2 diabetes. The medical management depends on what type of diabetes you are. For either type 1 or type 2, we really want to encourage them to exercise and eat well. That's a big component for both. Exercise actually reduces your need for insulin, especially in type 2 diabetics. Type 1 diabetics, you're going to need insulin regardless. But if you exercise, it actually can help need a little bit less when you're exercising. Not a lot, but anyway. And it also improves your circulation. Because we know with diabetes, there can be some damage to our smaller blood vessels. And so that can help improve the circulation. All right, during teaching, the nurse reviews insulin secretion in the body. The nurse is correct when she states the insulin is secreted where? Okay, you guys are so good. All right, so extra challenging question. What is secreted from the alpha cells? Don't answer that, Cameron. I know you know. Glucagon, yes. So on the outside of our pancreas, we have these alpha cells and beta cells. And we've talked a lot about insulin, how it kind of goes and helps to kind of unlock the doors to the cells to let the glucose in. But there's glucagon that's produced in the alpha cells. Glucagon actually stimulates your liver to release glucose. So they work kind of in this beautiful tandem where if you don't have diabetes and you just ate lunch earlier, guess what? Your blood sugar is beautiful right now because it doesn't matter what you took in, your body automatically started releasing the exact right amount of insulin and then kind of manage it out with the glucagon as well. It's beautiful. It used to make me so angry when I was trying to figure out with my son, like he could eat the exact same thing 3 days in a row and we would give three, like the same insulin doses and he would have wildly different reactions because sometimes it's you're not feeling good as a patient. Maybe he's not feeling good. Sometimes it was the weather. Sometimes it was the bread was left in the fridge and then we warmed it up. Like literally, there's so many things that just don't make sense. But if your body has a working pancreas, it's magical. It just does it all. But glucagon is what kind of helps. It's the other side. It's the opposite of insulin. It's if your body notices your blood sugar is getting low, like maybe yours is now after eating the candy, it's going to produce some glucagon to help give you a little glucose in yourself. Okay, I think we need to take a break. Let's take a break. Maybe go get some glucose in your cells. Let's come back at 10 after. We're going to finish this, do a little bit of work with diabetic meds, and then case study and we'll be done. Okay, thank you guys. And here, let me fill up the candy so we have more if you guys need. Isn't this awful?
I know.
Talking about diabetes, how do we make them more?
Yeah, right. Very useful. God, we go to the water. No way, you've been making it through without. So. You just keep going. You're too knowledgeable.
Thank you. Hey, you're welcome. Yes.
I needed, I have to.
Oh, dear. Moderation.
Yeah.
I know I'm like, no, I know, of course.
Just
but
getting
I don't think secondary nurse.
It's a lot of stuff.
I better.
Our recording here. And click in. Okay, so name that diabetes. We'll need insulin therapy for life. You should know this.
No.
Yeah, type 1, right? Because type 1 doesn't produce insulin. They will always need insulin for life. Can often be managed by weight loss and diet. Yay, nice job. Type 2. Now, weight loss and diet will help type 1 diabetics, but it won't necessarily, it doesn't take away the need for insulin. Treatment will usually begin with oral hypoglycemics. Yeah, good job. Type 2. What treatment is begun with type 1 diabetics? Insulin, right? Mhm. Which is at bigger risk of DKA or diabetic ketoacidosis? Yeah, type 1. Good job, type 1. I think. Okay, oh, go back. So we're gonna break up into some groups. So before you go, I'm gonna give you a couple of instructions. So oral hypoglycemics or oral diabetic medications. One thing to know, they're not insulin. Anybody know a real common oral or a common hypoglycemic or diabetic medication? Metformin, or not even oral, some injected ones. What's one that's really common right now? Yeah. Ozempic. Yeah, it's a diabetic medication. It can also be used, some of these can be used for weight loss. It depends on the medication, but usually what they do, they either stimulate the pancreas to produce more insulin. They might increase the tissue sensitivity. So if you have some insulin resistance, it might make them a little bit less resistant. It might slow carbohydrate digestion. Like a lot of these people on Ozempic, they're like, oh, I feel nauseous because we're slowing your digestion, right? Things aren't moving through like they should. Sometimes they also reduce the glucose reabsorption. There's a lot of different factors of how they work. What I'd like you guys to do, each group is going to have a different type or a class of medications. They're all in your book. I don't have the page numbers right now, but I want to keep it really simple. I want you guys to give me a common drug name. What's one that maybe we've seen in a commercial? Don't give me lots, just one. Then an action. And what I want you guys to do is maybe if you want to be fun, act it out. Like you're pushing the insulin, like I'm trying to act out things. I think it really can help you remember too. Think about a way, if you feel comfortable, how to act it out or how to explain how it works. Like how you would explain it to a patient, right? Like not just it works by this like very high language stuff. No, break it down. Very simple, just a few sentences. The next one, common side effects, top 3. Don't give me all the side effects. What are the top 3 side effects that we see? Do you know in your drug books or like how to know what are the top 3? They're listed first. Side effects, when they're listed with medications and drug guides, the more common ones are listed first. So the first 3 are the most common ones for most drug books and most places. So easy hack there to learn. And then I want you to list 3 nursing management actions. So as a nurse giving this medicine, what would 3 things be? So give me the name, figure out how to show us the action, 3 common side effects, and 3 nursing interventions. All right, I'll let you guys choose. No bag of equity today, just 6 different groups.
You want
Here, 6 times.
six.
You wanna write? Yeah.
You're right, it's like
I'm not writing my third again.
So what's
What should we miss? You can write, you can do your. Oh, okay. They're all. You don't wanna know.
Oh, yeah, we were just talking about, oh, never mind. I did not get the head.